Part 2 of the initial certification examination process by the American Board of Physical Medicine and Rehabilitation is an oral examination. Candidates will be presented with patient vignettes in 3 40-minute sessions. Candidate performance on each vignette is evaluated in 5 domains. These are data acquisition, problem solving, patient management and treatment, systems-based practice, and interpersonal and communication skills. The vignettes are structured to assess competency in the 5 domains. They are not intended to replicate all aspects of a case seen in practice. Content areas from which vignettes are designed are listed in the appendix to the booklet of certification on the ABPMR website. When the examination begins, you will receive a brief written description of a patient presentation. As the examination proceeds, further details are added to the vignette as you work through the evaluation and treatment of the problem. Your examiner will ask questions to guide you through the 5 domains tested in each vignette. It is to your advantage to be efficient and stay focused on the specific problem and to explain your thinking out loud. Data acquisition. After you've read the brief description of the patient presentation, your examiner will prompt you to request further information about the patient. This could include additional history, physical examination findings, and functional assessment. The examiner may provide you with additional information in response to your answers. The examiner will assess if the candidate elicited the appropriate data to correctly diagnose and manage the problem. Problem solving. You will be expected to integrate medical knowledge with the clinical data. The examiner may ask you to provide a differential diagnosis and the most probable diagnosis. It is to your advantage to explain why you are considering or ruling out specific diagnoses. You may be asked to state what further workup should be done or to evaluate data. The examiner may provide you with additional information in response to your answers. The examiner will assess if the candidate approached the clinical situation in an organized manner and proposed reasonable diagnoses. Patient management and treatment. You will need to delineate medical and rehabilitation treatments for the patient and explain your rationale for these treatments. These can include management of medical problems, prioritization of medical and rehabilitation goals, exercise and modality prescription, prescription of durable medical equipment, therapeutic and diagnostic injections, and patient monitoring and follow-up. It is to your advantage to use evidence-based decision-making. The examiner will assess if the candidate developed an informed and appropriate treatment plan. Systems-based practice. You will need to use your knowledge of practice and delivery systems to integrate the patient's management within the larger system of care. This could include the level of care appropriate for the patient, potential risks and benefits, considerations of limitations and costs of resources, patient advocacy, use of medical or surgical consultation, team management, quality of care, or patient safety. The examiner will assess if the candidate made appropriate decisions regarding use of resources and consultations, if the candidate properly considered risks, patient safety, and quality of care, and if the candidate is an appropriate advocate for the patient. Interpersonal and communication skills. You will need to demonstrate your communication skills with patients, families, or other health providers. The examiner will pose a question to you and ask you to role-play answering that question to a patient or family member or provider. It is to your advantage to focus on your communication style and to use patient-centered language. The examiner will assess if the candidate can respond sensitively and ethically and provide appropriate explanations to patients and families or communicate effectively and professionally with consultants and hospital staff. The following is a sample vignette. The types of questions posed by the examiner will vary with each vignette, and this example is not meant to be all-inclusive of the types of questions encountered in an actual Part 2 examination.
During the next 40 minutes, I'm going to be asking you questions about certain specific patients. Now, please focus your answers on the specific patient problems and explain the rationale for your answers. I'll be moving you along so that we can cover enough material, and I'll be taking some notes to help me score your answers. If you want to take any notes, you can use this pencil and paper, but you need to leave this in the room when we're done. One thing more, during the course of the exam, an observer may come into the room. He or she is there to observe me, not to score you, so please don't pay any attention to the observer. Are you ready?
Yes.
All right, let's begin. Here's the first case. Why don't you read along and I'll read it aloud. A 14-year-old boy who sustained a severe traumatic brain injury 4 months ago presents to your clinic with his mother. His mother requested the evaluation for readmission to inpatient rehabilitation because of deterioration in function. He was discharged from your rehab unit 6 weeks ago. 2 weeks ago, he was admitted to neurosurgery for cranioplasty to repair the craniectomy done during the acute care management of a subdural hematoma with cerebral edema. What additional information would you like to know about this patient?
I'd like to know more about the original injury, how he was injured, what the CT scan showed, how long he was in coma, and if he had any seizures or other complications.
Well, he was skateboarding down a hill with no helmet, and he struck a car with his head. His CT scan showed a right frontal contusion and a left subdural hematoma with midline shift. He was in coma for 3 weeks, and he did not have any seizures initially.
What was his function at discharge from rehab, and what's different now?
At discharge, he could ambulate limited distances indoors with a walker, and he used a wheelchair in the community. He needed cues to stay on task for his ADLs, and he had word-finding problems and difficulty understanding longer and more complex information. Now he has poor balance and he stumbles. He seems very tired all the time. His speech is slurred and his memory is worse.
When did the mother notice these changes?
She's not sure. He's never really seemed his old self since the surgery.
Did he have any complications from the surgery?
After the cranioplasty, he had some lip smacking associated with oxygen desaturations.
Did the neurosurgeons feel these were seizures? Was he treated for them?
Yes, he was started on Dilantin.
Okay.
I would like to know if he had any other past medical history.
No.
Is he on any medication?
He's on Dilantin and a multivitamin.
I would ask for a review of systems, see if he has any other complaints, change in mood, incontinence, or seizures.
The rest of the review of systems is negative.
On physical exam, I'd like to know his vital signs and physical general appearance.
Vital signs are normal for age. He's awake but tired appearing.
I would do a full exam to rule out infection and other health problems and focus more on the neurologic exam.
What would you like to know about the neurologic exam?
On cranial nerves, are the pupils equal and reactive? Does he have normal eye movements?
Pupils are equal and reactive. He has nystagmus on lateral gaze.
Does he have any spasticity or hyperreflexia?
No spasticity. His right-sided reflexes are slightly more brisk than on the left.
I think I'd check his balance and gait.
He has poor standing balance, and his gait is markedly ataxic with loss of balance.
I would do a mini mental status exam.
He's oriented to person, has dysarthric speech, 0 of 3 recall, and he needs repetition to follow commands. Okay, let's move on. So the patient has decreased balance and alertness and new nystagmus compared to his discharge from rehab. During the hospitalization, he had lip smacking with oxygen desaturations, and he was started on Dilantin. Now, he's had no further episodes to suggest seizures. What is your differential diagnosis for this deterioration of function?
He could have developed hydrocephalus. He may have had it subclinically all along, but it didn't show up until after the cranioplasty when his brain was enclosed in a fixed space again. He could have had a hygroma or rebleed in an area of his subdural. I forgot to ask if he had any recent trauma. He could be having subclinical seizures, or he could be having a side effect of his medication.
What tests would you order, and why?
With impaired balance and nystagmus, I would be very worried about dilantin toxicity. So I'd get a stat dilantin level. I would also check electrolytes to see if he has hypernatremia. If those were within normal limits, I'd get a head CT to rule out hydrocephalus, a hygroma, or a rebleed in the subdural. If that was normal, I would order an EEG and refer the patient to neurology.
Now let's focus on patient management. The patient had a dilantin level of 51. How would you manage this patient?
I would consult with neurology. This level of dilantin could certainly explain his change in function. I know that high dilantin levels can cause ventricular arrhythmias, but I don't know if 51 is high enough to do that. So I'd ask neurology if the patient should be admitted for cardiac monitoring.
The patient was admitted to neurology. His dilantin was stopped. 3 days later, his slurred speech, nystagmus, and ataxia have improved, but he's still very weak, and he can't use his walker for more than 5 or 6 steps. How would you manage that?
I think the most likely situation is that the patient has become deconditioned by the recent surgery and then the dilantin toxicity. I would have PT, OT, and speech evaluate him in the hospital to see if he has lost skills in any other areas. I wouldn't have expected him to. I'm assuming we need to focus on a strengthening and endurance program now. Because he doesn't really have multidisciplinary needs, I would try to send him home and get him into outpatient therapies. And I'm not sure if he has the stamina yet to reintegrate back into school, so I may postpone that for a while and focus more on getting him back to his recent baseline. To specifically address the endurance, I'd like him to have PT 3 to 5 times a week with home exercise programs as well. He could start with walking the parallel bars, doing upper body TheraBand and cycloergometry. If the outpatient therapy site has one, he would also be a good candidate for using a light gait trainer to help build up his endurance once again. I'd want to check him back after 3 to 4 weeks to see if he was back to his previous level of endurance.
Let's return to the issue of the dilantin toxicity. How might this adverse event have been prevented?
Well, obviously someone should have gotten a dilantin level.
Yes, but what systems issues could have contributed to this?
I can think of several ways in which this may have occurred. First, he may have been prescribed the wrong dose. So is there a pharmacist who reviews medication orders? He may have been given liquid dilantin, which doesn't dissolve very well. So unless the mother was diligent about shaking it, she may have been accidentally overdosing him once she reached the bottom of the bottle. So deciding which type of medication to use is another concern. Can he swallow pills, or does he need a liquid form? And did the pharmacy dispense the right dilution for the right dose? Did he have levels drawn in the hospital? And if so, were they stable or rising? If they were rising, the physician should have gotten further levels. Did the physician inform the primary care doctor of the new medication? And was there a plan to check levels then as an outpatient? Did the nurses or pharmacy inform the family of possible side effects to be aware of? If the outpatient therapist noticed any change in his functions, who did they contact? So there are a lot of people and services who could have been involved in this.
A few days after the patient goes home, his mother calls you. Now, pretend I'm the mother. Doctor, I've been thinking a lot about what happened to my son, and we're very upset. We're grateful for your help, but we don't understand how this happened. 2 days before he saw you, he was seen in the neurosurgery clinic, and they didn't recognize this for what it was, and they're the ones who prescribed the medication. To be honest, we're considering a lawsuit.
I'm glad you called me about this. I want to say I'm very sorry that this happened to your son. Fortunately, this doesn't happen very often, but I've seen it before. Sometimes, even in the hospital, a patient's levels can get out of control, and it can take us a while to recognize the symptoms. I'm glad we caught it when we did, and the good news for your son is now that the dilantin is out of his body, he won't have any lasting problems because of it. I know it set him back a few weeks, and I'm sorry for that. But I think with some additional therapy, we'll have him right back to where he was before.
But why didn't they recognize this at the clinic?
I don't know, but I would like to report this to our Safety and Quality Assurance Committee. They'll look at it from all angles and see what they can do to prevent it from happening again. But if you like, they will call you and tell you what they decide to do.
Thank you. Let's go on to the next vignette.
We hope that you have found this video demonstration of an oral examination to be helpful. During the examination, you will cover vignettes with varied content given by 3 different examiners. Each vignette will focus on the 5 domains described, but not in exactly the same manner as this vignette. Scores from all the vignettes provide a composite score for the examination. It is extremely important that candidates keep the content of the examination confidential and remember not to discuss the vignettes with others. Further advice about test-taking techniques is given in the Part 2 certification examination information for candidates on the ABPMR website.